Technology and Policy, IIT Madras. In the past,
what happened to you, Sudarshan?
And we check if there is any video. Let me just continue then. See, Professor Muralidharan needs no introduction because he is one of the most eminent health policy experts in India, has worked with many state governments as well as national government. And he is also the professor in charge of Center for Technology and Policy, IIT Madras, which is actually a think tank at IIT Madras to act as an interface between technology and public policy. And he was earlier the head of Center for Sustainable Development at IIT Madras. And he was also professor of in charge Lemelson Recognition and Mentoring Programs. And he was also head of the department for almost 7 years, Department of Humanities and Social Sciences. I welcome Mr. Rajesh Singh, Dr. Rajesh Khanna, and Dr. R.K. Sivasava to the program today, and the Wish Foundation, Mr. Kapil Zutsi. I hand over the microphone to Professor Muralidharan to introduce the speakers and take the event forward. Thank you very much.
Go to the next slide, please. Good afternoon, and on behalf of the IIT Madras and ADO, I would like to welcome the special speakers of today, as well as all the participants who are present here on the theme of role of innovative primary healthcare towards sustainable development. Yesterday, we had a wonderful launch in which various speakers, the guest speakers and the chief guest and president of the ORDO organization had spoke elaborately on the importance of primary health care. As such, the underlying lesson from all the various points made yesterday was, if I may put it telegraphically in one line, is that to the extent we strengthen primary healthcare delivery system in our country, in our state, to that extent, the overall efficiency of the entire health system also improves. So I don't need to elaborate on this because everyone here were also present, I suppose, yesterday. Even if you had missed that point yesterday, or you were not present yesterday, I'm sure listening to the speakers today and the next 2 days will emphasize the importance of what I summarized today a while ago on the importance of primary health care. So today we have three eminent, highly experienced people in primary health care. We'll begin with the presentation of Dr. Rajesh Singh, who is a social entrepreneur and a specialist in civic participation, public health, and non-profit sector. He has a wealth of experience and expertise in monitoring and evaluating international development programs. He has been a member of many committees involved in developing strategic guidelines and framework on public health issues. Currently, he is the chief functionary at LESH Wish Foundation, heading the organization as Chief Executive Officer. May I now request Dr. Rajesh Singh to make his presentation. Welcome, sir.
Thank you, Professor Muralidharan. Thank you, IIT Madras team. Thank you, ADO team. Ladies and gentlemen, participants, welcome to this forum. Let me just thank you all to really invite us and allow us to present our learning. Before I really, the Wish Foundation and Professor Muralidharan and Professor Sudarshan. The genesis of Wish Foundation is one of the IIT Madras alumni, Mr. Sunil Wadhwani, who is a pass out of IIT Madras. He actually founded. He coming from a technology background, when he decided to invest in primary healthcare, and the reasons were very clear. I think 90% of human needs can be addressed at the primary care level. That's one. And our own experience, we realized that almost 67% of the health needs within the primary care in urban and rural, what we saw are basically the four kind of cough, cold, fever, and skin diseases there. Considering that, like, Sunil started to invest and he became our founder donor, and we are still like, he remains, the mentor, the guide, the philosopher for us. So thank you, IIT Madras, for giving us this founder donor to us. And thank you, the team, for allowing us, inviting us to share there. So we have three of us. I represent the institution. I will talk more about our digital experience within the primary care lab. The second is Dr. Rajesh Khanna. And the most, Dr. Khanna will talk more on the urban health, the models that have evolved, developed, and scaled within the public health system. And Dr. Srivastava, who is the former DHS Government of India, has, both of them are clinician, physician, and he will talk about primary care and the futuristic aspects. We just divided that. We'll be very happy to really take the questions at the end, or also as you feel comfortable there. Absolute privilege for all three of us to be invited, and thank you for giving us this platform to share our learnings there. I've already set the tone for why the primary. Can you enable me, Professor Sudarshan, for me to put my slide there? So we started our first model in rural primary health, and that model we piloted in within the government primary health setup. The reason we didn't really wanted to deviate from the government setup, the public health system, was very clear. We all can work in a silo in and outside the government system, but when you really bring it to the government system, it always has a challenges there. And then we also maintain a cost aspect. So how cost effective this can be. And then if it's cost effective and within the larger public health system, chances of scale or scalability is very high. And that's something that we learned very high. And that's the reason 100% of work, what we do currently in different parts of India, we actually work within the public health system only. Professor Sudarshan, I think you have to allow me to host my PowerPoint.
Yeah. One second.
Sudarshan.
Yeah, I'll just do that, sir, because I'm not able to reach that person. Just a couple of minutes. Okay. Yeah.
The slide is not with you?
No, I can't host because
he has to be made the host, sir. That is it. I'm just trying to get the Lisa or somebody. Can you just make Mr. Singh the host?
Or you allow me to just share the screen. I shouldn't be the host. You just allow me. There is a system to allow.
Let me just just 1 second, sir.
Sir, give me a minute. We are working. We will just allow them.
Mostly if you see, and I'll take advantage of this time, mostly if you see that the critical challenges in the primary healthcare are inadequate, provisioning of the center there. Both in Indian system, you have HC, and within that, you have sub-centers there. Now, 30% of rural population doesn't have access, or the PHC is around 5 kilometers from their houses there. So that's one challenge. Second is, of course, we all know that the health professional challenges, we don't have those many, the colleges, medical colleges or nursing colleges, and they have a limited capacity to produce the talent there. The third one is accountability also. Their services are there, but the quality is a major aspect of that, major issue on that. So clear accountability part there. Then, of course, the supply chain of the drugs and the reagents, if it's related to any kind of vaccines and others. The fifth is also it's only not limited to the facilities there, healthcare facility, but the whole promotive and the preventive aspects within the primary care is also missing. And it's limited to the A&M and within the Indian public health system there, especially from PHC. And then the most important, the non-communicable disease, which that is really impacting human lives there. I think we are not yet prepared to handle non-communicable diseases. Considering that, what the government of India has done, and many of the speakers yesterday may have spoken about that, they have actually increased the basket of the services, initially from 6 or 7 to now 12. And diseases like issues like geriatric care, mental health, wellness like yoga and others have been really embedded. And I'm really thankful that the government of India took this when we were developing our model. So it was easier for us to start positioning, convincing, and pilot, developing these models as a proof of concept within the public health system there. On the digital health part, what we realized is that we were taking one step ahead, but infrastructure were not there. Public health system, like, safety, security of equipments were challenged. Electricity in most of the centers were actually not there. Then connectivity, if we go to the digital, connectivity becomes a very important aspect there. Poor connectivity. Then also the data system was quite weak there, right? Of course, everywhere we keep hearing in third world countries that the supply chain aspect of the vaccine that I really thought as a challenge was a real challenge there, right? Drugs were out of stock.
Yes, sir. I'm sorry to interrupt. The permission has been given. Thank you, sir.
This meeting is being recorded.
Thank you. Great. The last one is
There's something wrong with the hello. Some problem with the Sudarshan. What happened?
Now, actually, the internet went down in the institute, so they are somehow managing to connect. That's why Rajesh, they could not actually make Rajesh the host. Now I think the internet is back, or they are doing it through some other way.
Sir, can you try again now speaking?
Can you hear me, sir?
Yes, sir. You can ask the audience, those in the audience, are you able to listen to him now?
Yes.
Yes, sir, able to hear you.
Thank you, sir. Thank you sorry for the inconvenience.
I took advantage and I shared the key elements of this slide. I'm going to really move, right? So what we did is that, and is the slide visible to all of you?
Yes.
Yes, sir.
Yes.
Great. So considering all the above challenges, we still decided, and we call it a 3A principle. Sometimes we also call it a 4A principle. 3A more, accessibility, acceptability, and affordability. One more part that we really sometimes use is that availability. So what is accessible? Services may be accessible, but your doctors, paramedics are not, or medicines are not available. But in our model, we address that part. Availability, we ensured it. So accessibility, we first address it. Second, things can be accessible, but a simple attitude of the healthcare provider may actually be a deterrent of acceptability part. And the most important is because we were working in the government health system, we really made it affordable there, right? We always compare it, how we can be more cost effective from the government primary health centers there. And we managed the cost very well over a period of time there. The 3 models that we developed, one is the rural one, where we completely transform it, both rural and the urban within the government primary health setup. Second one we developed with Dr. Khanna will talk more on that. There was a complete vacuum between urban PHC and the client, which is the community. Sheer population was one reason, lack of human resources and all those. We also address that gap. Third, that to address many of these challenges, we use the digital part, digital as, so we call it tech-enabled health and wellness centered model. And we did it both at the sub-center level and the primary health center level. And all these things we really completely digitize with the aspect that A, we have a improved services, B, we have a quality services, C, we have improved data and real-time data. And as a result of all, quick action was taken at our end over a period of time. And all the learnings over a period of time, what we did is that we didn't want to really keep replicating everywhere. We converted into a knowledge management center and technical support. And each of the new states, wherever we go, we say that we are going to actually bring the learning of our long 6 years learning, and we are going to provide the technical support to the state there. And in 3 out of the 5 states, actually, or 4 out of the 5 states, we are a technical support for primary health in this. I'll talk a little bit about the digital health and wellness center that we really talked about. What we did is that if you see this, we really use the digital for the demand generation side. So a lot of digital tools and platforms were utilized to generate the awareness. We also, at the community level, urban ward level, that's in India, we call it ward, and then you have village and helmets here. The frontline health functionaries, which is ASHA, which is the frontline in India, every 1,000 population, you have an ASHA. We use them extensively. We also use the auxiliary nurses, midwives there. And so anyone within the community actually needed the health attention. We really diverted to the near digital health and wellness center, which is within the sub-centers there. What service the sub-center does, once the client really reaches or the patient reaches this sub-center, they get the services, the first level of care and screening. And we have various point of care devices there, which is in the, you can really, and these are the point of care devices which we piloted over a period of time. We source it from Department of Technology, Government of India there. We also have medicine dispensing part there, because as per the government regulation, the ASHA or A&M cannot dispense the medicine. We increased the basket of the medicine from 17 to 82, but in general, around 57 common medicines are available there, and it's medicine vending machine which dispenses the medicine. We also improve using the digital, improve the whole data capturing, and then the referral was very easy because we used the digital to from there to PHC and PHC to CHC there. Once the patient, if he or she gets the complete treatment, or if there is need to really forward it for any kind of diagnosis, we further send it to PHC. Again, there is services of teleconsultation, there is services of digitized diagnosis. And there is also, Government of India has come out with this Prime Minister Jan Arogya Yojana there, which is actually the insurance part there. And we started linking patients who falls into the PMJ criteria, there are fixed criteria there, to avail the insurance part there. And we do the real monitoring. There is a possibility from the sub-center, the patient can directly be sent to the district hospital or sub-district hospital or CHC or even a super specialist, which is medical hospitals there. Or the patient can come to PHC and go back to the community. What normally this clinical client pathway is showing is that how patient normally moves from sub-center PHC to district hospital, and how the closure gets really, the loop gets closed is that from the compliance perspective, we do the follow-up the patient when the patient comes back to the community or the home they're setting. So a lot of counseling part and secondary and tertiary kind of care by the ANM or someone from the family who does it. but the data shows that over the last 3 years, how some things have evolved. If you see this, we were doing great before the wave 1, and you will see that in year 19, we had 65. So DHWC number are 65. In 20, we went to 66, and 21, we went to 100. So if you see the number, the COVID wave 1 came in, everything was stopped. The primary health centers, sub-centers where government asked us to really stop the functioning there. And there was a complete lockdown. Whereas in wave 2, they allowed people to work, especially when the government passes there. We also, but many of the human resources were working deputed on our HWC, Digital Health and Wellness Center. They got diverted to either vaccination or surveillance there. So if you see this wave 1, we were still grappling, understanding, we were in a complete lockdown. In wave 2, lockdown didn't impact us, but what impacted diversion of human resources to a priority task by the government there. Wave 3, we all learned from there and we handle all these things well. And if you see this, our numbers never drop there. We have a general and a specialist consults there. So almost 7 or 8 kind of specialist consults happen on a day-to-day basis there. These are the data which really shows that on a specialist side, gynae, 37% of the people who approached services or received, they went services. 27% to pedia, 15% dermatology. Orthopedic and geriatric population are quite a lot, and dermatology during the harvesting and sowing season was much more, and in urban where industries are nearby there. This is the numbers which really shows the gender segregation, and you will see this the female beneficiaries almost 53% there, right? It's really the primary health. If you see who doesn't have access to the services in a third world and especially Indian context because of various cultures, it's the female. And this kind of primary healthcare, where if you really work on the quality of the services, if you work on the skill, both soft skill and hard skill of the service provider, if you really bring technologies there, and you track the data on a day-to-day basis, I think the beneficiaries get benefited immensely, and especially those marginalized especially the female who doesn't have, you create an access to the services there. The data is very much that around 3.5% of the people who availed our services, we did, we referred them. And sometimes even a specialist gynecologist will really refer to, sonography or any face-to-face kind of interactions there, because, not everything can be handled there. Those are the data that is talking about our model. I'm happy to really take any question if you have. Please feel free to, we still have a couple of minutes.
So typically, we can ask people if there is any question now, or again in the later after the presentation. We have 30 more minutes wherein they can come back and ask you questions. Audience, anyone in the audience would like a quick clarification, comments before move on? Because I don't see any question post yet on the chat box.
Great.
So in which maybe, since it is all three together gives a complementary picture of the WISH efforts, perhaps we will move on to the next one and then take questions, sir. Is that okay?
Thank you. Thank you.
Yeah.
Over to you, Dr. Rajesh Khanna.
Yeah. So before Dr. Rajesh begins, I would like to make a brief introduction of him. Can we have the slide? Or I can read out. Wait a minute. I think I have a slide. Yes, I have it with me. So I have the pleasure of introducing Dr. Rajesh Khanna, who is a medical doctor trained in pediatrics and public health. He has served as a technical expert at international level with various reputed organizations like NIIC UK, WHO Geneva, and CRO, and Global Technical Leadership Group of the Save the Children. Dr. Khanna has a keen interest in bridging the gap between research, policy, and programs for developing healthcare solutions for most vulnerable population, adopting a people-centered approach. With this brief introduction, I welcome Dr. Rajesh Khanna to make his presentation. Dr. Rajesh Khanna.
Yeah, very good afternoon. And first of all, sincere thanks to Professor Muralidharan, Dr. Padmabhan, and all my friends from Asia and Africa. Lovely to see you and welcome from India. I'll just share my screen, just hold on. Yeah, is everyone able to see it?
Yes, sir.
Yeah, okay. The reason why, first of all, thank you once again for inviting me to this wonderful platform to share. And I will be speaking on a topic which is something probably, though I will be giving examples from India, but I'm sure this is a problem that we are all going to face in the near future. And that is about how do you strengthen primary healthcare for the urban poor population. Now, the reason is that why are we talking of urban poor, first of all? Now, this is a modeling exercise that has been done in India, where we are seeing, we all know that probably India is one of the fastest growing economies in the world, but it has its implications, and especially in terms of the way it is rapidly urbanizing. Now, within that urban cohort, where we are seeing is that probably by out of 1.3 billion population, by 2030, nearly 600 million people will be in urban situations. They will be moving to urban scenarios. And this population is going to increase to more than 800 million by 2050. The biggest challenge is that probably 1/3 of this India's urban population lives in squatters or unhygienic conditions, I would say. Now let us look into what happens. Usually people move to urban scenarios for better job opportunities. And there's huge terms migration. Now that leads to overcrowding and stretching of the infrastructure. You know that the systems are already overburdened and you have more migration coming up. As a result of it, what happens? These people will have to move towards the outskirts of the city, living in unhygienic conditions, slums, which make them more prone to both communicable and, because of the infrastructure and other problems, your non-communicable diseases go on rising. You have a dual burden of disease happening place. Now, the biggest challenge in urban scenarios vis-a-vis the rural scenarios is that the social determinants of health play a very important role in determining their health status. And when I'm talking of social determinants, it means their education, crime, the way the city is structured, their entitlements, food security, agriculture, access to food. So everything comes together, and these factors play more of your doubling effect on the poor adverse outcomes that these people face. I'm going to give you a context of the rural versus the urban scenario in India. Now, the left side structure is a well-formed rural primary health system, which starts from the village, go on to a sub-health center, which is at the level of, say, 5,000 population. Then it goes to a primary health center, 30,000 population, and then you go to a block level hospital. Now, this model, when it, we had a huge push on the primary health system coming through the National Rural Health Mission, which I'm sure you would have heard yesterday in 2005. But in 2013, with rapid urbanization, the government realized that it was important to start focusing on the urban poor population. So a new structure was defined, and you had the National Urban Health Mission, where the primary focus was on how do you strengthen the primary health system for the urban poor and the other vulnerable populations. Now, if you look into the model on the right side, you had at the community level, Mahila, women groups. Then you had the auxiliary nurse midwives. Now, these auxiliary midwives were working through a virtual sub-center. There was no fixed center for them. And then you had the urban primary health center, which was providing outpatient services for about 50,000 population. So in a way, there was no mechanism of service delivery less than 50,000 population. Coupled with it, we all know that in urban scenarios, the primary health centers, which had, because of the lack of space, shortage of doctors, the primary health centers are usually built in a place which are not accessible for the most vulnerable sections of the society, because there is no infrastructure, there is no space for them to be built. Now, I'm also shifting your focus now to the data. Normally, when we are talking of the urban poor, we feel that probably they are living in urban cities, so they should be in an advantageous position. I'm showing you a data from our National Family Health Survey 3 and 4. Now, the urban data has been disaggregated by urban poor and the urban rich. Now, if you look into the various indicators, and I will just highlight 4 indicators out here. If you look into the total fertility rate, you find that in rural, it decreased by 20% from 3 to 2.4 in a gap of 10 years. Whereas in urban poor, it decreased by less than 10%. So apart from the fact that the TFR in urban poor now is more than that of the rural population, and the reason has been the disproportionate slow decrease in the urban poor indicator. Similarly, when you look into the home deliveries, I'm sure everybody, my friends from Asia and Africa, would be aware that India has a huge program of promoting institutional delivery. But still, this is NFHS 4 data, which I am showing the latest one, because NFHS 5 has come, but we don't have disaggregated data for urban and urban poor. It will take another 3 to 4 months to get that data. If you look into the home deliveries, it decreased by nearly 1/3 in rural, but in urban poor, it decreased by half. And again, the home delivery rate is more in urban poor. Full immunization status, similarly, in rural increased by 60%, whereas in urban, it was 35 to 40%. Interestingly, there are 2 more important factors related to sanitation and cooking. Access to clean fuel for cooking, which was not there in NFHS 3. But if you look into it just as an isolated, you find in urban poor, access to sanitation facilities is literally half that of the rural population. There is a national program which is focusing on improving sanitation, ensuring universal access to improved sanitation for all. But again, here, the urban poor are lacking. Another point which I want to bring in is what happened at the time of COVID. You all thought that probably the rural populations are the ones which are the most impacted. This was a study, rapid assessment done by Save the Children, and they found that again, access to your routine primary healthcare services like antenatal checkups, immunization, and postnatal checkups was much lower in terms and for the urban poor population as compared to the rural. And I think one point which I would highlight, 12% in rural population did not have access to any of these essential services, whereas in urban poor, it was as high as 28%. So friends, we always feel that probably living in urban scenarios gives you an advantage. But is it true or is it a myth? Normally, we take into consideration, we always compare average versus urban, rural versus urban data. But it's very important to disaggregate this data, and because the average usually hide the inequities. In urban scenarios, because of the varying functionality, the outreach services are limited. The primary health level in India has been functioning suboptimally. And as a result of this, your secondary and tertiary facilities get overburdened, because when people don't have access to health services for your simple ailments, like my Rajesh ji just said before it. So what happens is that leads to overloading and overburdening of the secondary and the tertiary facilities. Coupled with this is the problem of access, availability, and quality of services. And here it's usually the drugs and diagnostics. Usually it's the problem of drugs which leads to the high out-of-pocket expenditure in our country. Nearly 80% of the out-of-pocket expenditure, 70% is being contributed by drugs, and about 13 to 15% from the diagnostics. I will share with you now two models. Now, these models are a combination of both a system-based innovation and technological use. And I'm sure you would have heard a lot about Aam Aadmi Mohalla clinics, which is being run by the Delhi government. And then I will be talking of another primary health model, which is the Sanjeevani clinics. Now, the rationale for forming both these models was to provide the three essential Ds, that is doctors, drugs, and diagnostics for the urban poor, and providing them close to their doorsteps. Now, in a Mohalla clinic, first of all, I'll come to the Mohalla. This is an initiative by the Delhi government. And when it was being formed, they had reached out to Wish. So Wish has been supporting them in designing and then in scaling up this model across the entire state. At present, we have more than 500 clinics, but when it was started, it was a number less than 2 digits. So the idea behind it is that you establish it in the heart of the community per about say 10 to 15,000. The infrastructure is usually, because there is shortage of spaces, so either you take it on rent or any community spaces like your some space which has been used for dramas or for events, that can be taken, or there is a prefabricated cabin. A 4-member team has been assigned to this clinic, which consists of a doctor, nursing staff, pharmacist, and a multitask worker. When we started, the drugs and diagnostics were limited in number, but at present, the free services are being provided, which include an essential drug list of 125 and a list of 212 diagnostic tests, which are being given through a hub and spoke model taken care by a private laboratory. Now, a very interesting funding mechanism that came was that this mechanism is entirely controlled by the state government budget. And that all the staff there works on an incentive model. So a private doctor who works there gets about 40 rupees per consultation, a nurse 10 rupees per consultation, pharmacist 12, and a multitask worker gets 8 rupees. So everyone is on a incentive model. Now, in terms of timings, when it was started, it was usually the morning shifts that were started. However, since a major chunk of people who access these clinics and who live in the catchment areas, they are workers. So they usually leave early in the morning and they return home late in the evening. So a system of say about 25% of these clinics have now been started on 2 shifts. There is one morning shift and another shift starting from 2 p.m. till 7 p.m. in the evening. Now, the things how it has been scaled up is, this is the entire story, but I will not go into the details of it. But what I will be really focus is how now the digital consultations, the entire process is being digitalized. This was a process we started in 105 clinics and is now being gradually built up to cover the entire 514 clinics. At present, about 150 clinics are digitalized. However, they have moved from 1 tab to a 3 tab model, but the rest of them are in the process. Just a picture of the Aam Aadmi Mohalla clinics. So one is a rented premises and this is a prefabricated modular. Now I'm sure people will be very much interested to see the data, what is being coming. And that in that case, I will bring you to the Sanjeevani clinic where we have access because we have the 3-tab model working there at a much in all the clinics that we have. Whereas for Aam Aadmi Mohalla clinics, we are in the process of getting that data. Now, Sanjeevani clinic is MP was also a intervention that came up based on the need of the state. Now, Madhya Pradesh, the state of MP stands for Madhya Pradesh, and it is the 3rd largest state in the country and 5th largest in terms of the population. So they were the first state to roll out the National Urban Health Mission. However, over a period of time, they realized that things were not working, and especially when we were talked of the urban poor. So they had reached out to us, and when we got a chance, we took them to a visit to Aam Aadmi Mohalla clinics. They liked the idea, but they wanted to adapt it to their state mechanism. So a change, some differences came up in establishing those, and we helped them to establish and design this model. The idea was that this should work at a population of say 30 to 50,000, but primarily the focus should be on at least 30,000 vulnerable populations. So an entire mapping exercise was done based on these population norms, gaps were identified, and those facilities were then established. Now, an interesting thing which happened here in terms of infrastructure was that the state health department got in touch with the urban authorities, the urban department of the state. And the idea was a formal MOU was formed, and it was the responsibility of the Urban Development Authority to provide the space for these clinics. And it was not only the space, but a clean space with potable water, electricity, and internet facilities. In terms of human resources, quite similar structure, but the difference is that all of them are salaried. Now, in case of Sanjeevani clinics, when we started, the idea was that we thought because of the shortage of the doctors were put on an incentive model and the rest of the 3 other staff were put on a salary structure. However, when COVID struck, these Sanjeevani clinics were converted into fever clinics, and many of the staff contributed to the screening for COVID patients. As a result of that, what we realized was that the doctor's salary was going down because now they were not getting incentive on the basis of consultations. So the entire staff structure moved into a salary-based structure. In terms of drugs diagnostics, there is an essential drug list of 120 and 68 diagnostic tests here compared to Aam Aadmi Mohalla clinic where the diagnostic tests are more. In terms of drugs also, a very interesting thing happened because there were existing primary health centers in the state, in the urban scenarios. Initially, the drug procurement was guided through your UPHC. It is that the Sanjeevani clinic staff had to give their indent order to the primary health center, and then it was sent to the state. However, seeing the success of the Sanjeevani clinic, now the state has given them a mandate as a separate institution. So they are able to independently indent the drugs. So whatever concerns were there regarding the stockouts of essential drugs over a period of time because it was being routed through a primary health center has now been sorted out. Now, one of the big intervention where Sanjeevani clinic has worked better than Aam Aadmi Mohalla clinic was the use of real-time data app, which was known as the Sanjeevani app. And I will show you the results of it and how does it work. Another big change here is that because they had 2 staff nurses or auxiliary nurse midwives, the community engagement component is stronger out here. And these health workers have played a big role in creating awareness about COVID. And now we are going to use them for especially the chronic diseases like diabetes, hypertension for the screening. Now, this is how the 3-tab model works. Whenever a patient comes to visit this clinic, the health worker registers and does all the biometrics, vitals, takes the history, whatever is given routinely in them. And that is all entered into one tab. Then the patient goes to the doctor, where we had initially the ICD-10 classification. We then changed it to SNOMED classification. And now probably we will have to upgrade it to the ICD-11 classification, because that is something which is there. So here the doctor diagnoses, prescribes the medicines, and then the patient then goes to the pharmacist, which is again managed by a health worker or a staff nurse, and the medicines are dispensed from there. So in a way, this is a blended model, just contrary to what, difference to what Rajesh ji just showed in the beginning. You don't have automatic vending machine, but the medical dispensation is done by the staff nurse out there. Just to give you an example of the scaling up journey. Initially, when we started 2020, and I have data from 2 years, that is from January 2020 till December 2021, 24-month data. The clinics, there were 33 clinics in 8 districts, and now we have nearly 87 clinics in 22 districts. The data that I am going to share here is going to be only for those facilities which have been using this app for at least 3 months in continuity. Now, even though our clinics are more than 100 at this point of time, but this at present, the data is limited to 87, so that we have uniformity and we have taken care of the data quality issues. There have been more than 10 lakh consultations, 7.36 after cleaning. You can see clearly an increase in the number of OPDs by quarter over the past 2 years. Now, interestingly is that this is not only the repeat patients, because the repeat patients have grown by 11 times, but there are also new patients which have increased by 10 times. Another thing, it's not only, we all know that the main reason for our high maternal and newborn and under 5 mortality, which are the prime indicators for us to achieve the SDGs related to SDG 2 and 3, it has to start from the primary healthcare. And as Professor Muralidharan rightly said, that unless you strengthen the primary health, your health systems don't get strengthened. So your identification of high-risk women is something that we have seen recently over the last 6 months. Some data, but what we are seeing in the graph right side lower is that yes, the high-risk pregnant OPDs cases are increasing. We are seeing an increased access by pregnant women for ANC services. In terms of availability, nearly 12,000 tests have been done, which are predominantly 90% are blood tests, but good to see that you are also having radiological services and urine stool examinations being done. Apart from it, in terms of drugs, we have seen that except for few cases of drug stock out that we had, we are not seeing any drug stock out in the facilities, at least for the past 6 to 9 months. There is also an increase in the referral to higher facilities. But again, something nearly more than 300% increase, but we have to, something that we are now trying to catch is to complete the loop and to see what is the outcomes of those referrals. So friends, this is the model that was already there. You remember this model when I showed in the beginning. Interestingly, the service gap that was there, which is now being highlighted, is the new thought of urban health and wellness centers, which has come in. Now, recently, the government of India has been quite proactive under Ayushman Bharat to push the health and wellness centers. Initially, the push has been on rural, but recently, I'm very happy to share that the entire focus has been, especially with the 15th Finance Commission coming, on establishing urban health and wellness centers. And the idea what they are realizing is that these can be the spokes, and which can be connected through teleconsultation to an urban primary health center. And above 3 to 5 urban primary health center, there is an urban community health center which can act as a polyclinic for specialist consultation. Similar to what we have seen in the digital health and wellness center, a same mechanism is something that we are going to now try to develop it for the urban mechanism. So friends, no denying the fact that strengthening urban primary health care is going to be critical if we have to reach the universal health coverage and SDG targets. Interestingly, what we are finding is that digital health has a huge potential to take care of the systemic, complex health system issues which we have been seeing and which we have been facing. Similarly, in other parts of Asia and Africa, what we are realizing. Fortunately, in our country, now we have an enabling digital ecosystem. Recently, the National Digital Health Mission has come, which is providing the framework through which all these digital innovations can be connected. One important thing which we have learned is, unlike rural, which is a more systematic and well-defined structures, the urban primary healthcare models will have to be need-based, dynamic, and they will have to be flexible. You will have to be flexible. You can't just take one model and fit it as it is. It will depend on the population needs, governance, what are the existing systems. There is also a chance that as we move along, because of the availability and the issues regarding availability of hardware, IT systems, it can be a hybrid model. Not only digital, but hybrid model. Similarly, different models of maybe taking only the public health model versus the public-private models. Or within the model, some of the services being outsourced to private, like you are seeing diagnostic services being outsourced to a private sector. And I think one of the critical part, which probably I've written at the last, but which is also going to be very important, is the academia and research institutes like IIT Chennai and technology, they can play a really critical role. We are on the cusp of a digital revolution. And these systemic issues, we are talking of the use of artificial intelligence, machine-based learnings. How do we make use of data, not only for real-time monitoring, but to follow a patient or a beneficiary from home to the facility and back? Similarly, creating platforms for different sectors. Is there a mechanism where we can integrate all those sectors so we have a unified mechanism to provide health, primary health care in a holistic way? Thank you, and happy to answer any questions.
Thank you, sir. Actually, there is one question which would be of interest to all the presenters. So, because it's important, there is a question from Ministry of Health, Mauritius. I will read out that now. I'm sure you can elaborate on this later as well. So the question from the Ministry of Health, Mauritius, is that what are the technical requirements to be set up to set up a telecommunication service? So that's a very broad question from there. Would you like to tentatively say something now and elaborate later on, or to either you or the previous speaker and the next
Absolutely.
speaker?
No, thank you very much. So first answer will be, does the country has a guidelines, telemedicine guidelines? In most of the countries, they are emerging it. In the lack of that, like I think the WHO is the best, agency to use their guidelines, because most of the nations have really adopted or aligned there. On the technical part, if you really see this, first ensure that at least 2 Mbps bandwidth is there in place if you want to really initiate telemedicine work. Can also, whether you have a right kind of EHR there, and lot in the current situation last 4 years, but more so in the recent year after post. Sorry. Can you hear me?
There is some interruptions, but
Oh,
go on, sir. Go on, sir. Go on, sir.
So, I said that like first look into what the national guidelines. If each of the nation has, most of the nations have their telemedicine guidelines, especially COVID. It quite far, right? Second is in lack of this. If you don't have, look into the WHO guidelines there. But on the technical side, at least Mbps data, if you want a very good, smooth kind of communication between a patient and a doctor. Second, have kind of EHR or the software or the platform, and a lot of open source platforms are available in the market right now. In fact, look into that. Third is that service provider, and so someone who's providing these services. You have mostly doctors, and nowadays it's a lot of different models of telemedicine are coming, including Ola and Uber model are also happening. But in general is that you need to have a doctor on the other side, and you need to have a client or a patient on right. So what we call different hub and spoke model there. Do you have that established in the country, or can we do it there? Even one single doctor can really provide on an average in a day around quality services around 70-74, but in models like ours, even if it goes up to 80 or so, but we restrict it for 8 hours kind of services. If you want some of the point of care devices, which are screening, not necessarily diagnostic, you need to scout in the ecosystem there, right? And if you Government of India has some of those validated point of care devices, and we'll be happy to share. Professor Muralidhar and Professor Sudarshan can share, and NARDO team can share our email ID and contact numbers, and we'll be happy, honestly, to really. The last part is that infrastructure, at least some basic infrastructure. If you see in my presentation, I talked about that. Basic requirements, safeties, security of those equipments, and also, do you have a vital monitoring system? Because what happened, the first thing is vital checkup there. And nowadays, again, during COVID, a lot of those touchless, wireless, Bluetooth kind of vitals tools have emerged, and it's very, very cost efficient. In 700, 600, 900, these are the vitals which can really capture touchless. There are available in the market. And again, if someone has any difficulty, we'll be happy to guide you to really get it sourced from the Government of India certified like vendors there. I'm going to stop and hand over to you, Professor.
Yes, sir. There is thank you for the quick response. And one more question presented to Dr. Rajesh Khanna, though he touched upon it. This is a question from one Mr. Modo Gaye. He is concerned about the growing slums in urban areas. Are there any special thoughts on how to take care of the primary healthcare needs in the slums? That's the spirit of the question.
Yeah. No, I think, first of all, we have to recognize that, they are an important population. Unfortunately, we don't count them because they become unregulated colonies and we unauthorized. First of all, let's recognize that they are important. And then, I shared, both these two models, if you look, the learning has been that you have to have a need-based model. It cannot be a model you can just take it from anywhere and bring it here. Whatever systems are working in rural will not work. And this is a learning that we have seen in India also. When a National Urban Health Mission was launched, it was taking the learnings from Rural Health Mission and just taking it there. And a lot of those things have not worked in our country. After 10 years, we are realizing. Some things have worked, but some things don't work. So in urban scenario, especially for the slum population, you will have to be very flexible in your approach, whether in terms of infrastructure, where do you want to have a fixed clinic out there, or you want to have a mobile clinic. Sometimes just the mobile clinics can work. Or you want to have a mechanism where these people can be referred to a particular places, or you want to go a home delivery. But the main thing is, how do you want to reach out to those people? Take the basic principles of access, availability, and affordability, and couple it up with the quality of care. I think your basic things are done. And fortunately, digital health is now providing us as a mechanism or as a wonderful platform to take care of these systemic issues, not only in urban, but also in rural areas. Wherever you have systemic issues where doctors don't want to go, there are no healthcare workers, drugs shortage is a perennial problem, diagnostics is a major concern. So these all are diagnostic interventions which can provide us some solutions to it. But your approach has to be flexible, adaptable, and it can be an iterative process.
Also,
Thank
just
you.
add to Dr. Khanna's point, I think telemedicine can be, so not everywhere you can start the services immediately. You have to have government permission, infrastructure development. The easiest is that a simple tablet you can initiate, and you can work it in a hub and spoke model. You can work in an enterprise model where a shop owner can also keep this, and in case of any health requirement, a time can be fixed where the doctor who is sitting in the PHC can really provide it. So it has to be a very creative way to really handle it, to meet the unmet need of the primary health within the urban setup, and especially if we want universal health coverage there. Another question is, Professor Muralidharan is on tab on software. I think we have learned these lessons over the period of time. It all, like, I'm not saying that the tablet, but when we started the 105, what Dr. Khanna said, 105 Mohalla Clinic and the first tablet, none of the doctor were actually willing to use it. We only found one champion who we lost, unfortunately, in wave 2. And he agreed, a 68 years doctor said, I'm going to take this challenge and I'm going to. And he became a positive deviant there. And he, from 1 to 4, and then gradually the health system sent a notification that you will be paid only when you use the tablet and you start recording the tablets, the client's data on the tablet. So not 1, 2. On the tablet part itself, actually error, and there are human errors. If you don't want to use it, you can easily say that, oh, tablet is not. So we have a team initially who was actually doing the errands like this and running around to fix the tablet.
Yes, sir.
Payment was happening per consult. If it's not in tablet, chances were that you won't get. So people were that, they were very cautious in handling tablet, entering data. So multiple strategy, but yes, those are software. It does get hanged. It does breaks down. And I think it takes us around 3 hours to fix it, or 2 hours, depending upon where the team members are.
Yeah. So our experience also here shows that you need several patches, as they call it, over a period of time, both due to technical inadequacy, software, and connectivity. I had the opportunity of visiting one of your centers near Jaipur before COVID. And the first point you made about having a bandwidth. So there was a huge Airtel tower specially installed. And I think with the high bandwidth, that ensured that there's the consultation is free. Is not interrupted. So with this, we will come back to the questions related to these 2 sessions. We'll move on to the third presentation by 1 minute. Let me read out the brief introduction to Professor Rakesh Kumar Srivatsa, who will be speaking. He's the third speaker today. He's an orthopedic surgeon and by training, and public health expert by practice. His career passed through Safdarjung Hospital, Health Ministry, Medical Council of India, and now he works on primary healthcare through technology and innovation. He works with ICMR and several state governments to transform primary healthcare primary health care services, at which Dr. Srivatsa guides and directs their teams in that works on appropriate platforms for innovations and technologies, including digital solutions in primary health care within the broad framework of National Health Mission. Dr. Srivatsa, I request you to kindly make your presentations. Thank you very much. Dr. Srivatsa.
Thank you very much for Professor Muridharan. Thank you very much to both the previous speaker who has made the task much easier for me. I think their talk was well received. There are certain things which they have made very clear in their talk. And that pertains to the organization to which I belong. A small organization, if you compare it with the tall task of primary health care, which is being handled by Government of India, Ministry of Health at center as well as a state, which is a very small organization. It has worked there in primary health care for last 6 years. And during these last 6 years, what we have been able to achieve have been narrated to you by the two previous speakers who had been engaged with WISH in these activities for a long time. Now, surprising them, I would like to share with you, there are certain things which are very clear. The first thing is that changes are possible in delivering health care in a better way from the primary healthcare system. It was not conceived in this manner before 2000 when NHM or NRHM was not there. It became little bit visible up to 2012 when they have started investing in primary health care. And now it has become little bit more visible and is being appreciated more after 2017 when the National Health Policy decided to tell government that use technology for better health care. The National Digital Health Mission of 2018-19 and the Ayushman Bharat Digital Health Mission. So you can see the number of the patients who are reaching through the digital solution, either through Sanjeevani or through Aam Aadmi Mohalla Clinic, to get a consult, which was really very, very difficult once upon a time, to get medicines for which they have to run pillar and post, to get diagnostic care, which was just impossible at that time. Now the situation is changing. And I don't say that it is a very good, excellent model, but wherever we have worked, we have seen that there is a acceptance among the beneficiaries about the technology. There is a value attached to the digital primary health care, both in urban and
Your slide is not moving.
rural area, the end user, and there is a little bit participatory nature between public and primary system, so that they collectively address to reach to a solutions.
So your slide is not moving. Are you moving the slides?
I have yet not started moving side.
Okay, okay.
Just now start.
Okay, sir. Thank you.
Okay. So with this backdrop, let me try to take you to the brief journey of WISH Foundation from 2016 to 2022, that is 6 years. And thereafter, I will try to devote my 7 minutes to the future, what I foresee as far as the technology integration in the primary health care. Now the slides are not moving. Why are they? Chalo. Now we started our journey somewhere around 2016, and that time the basic vision was to introduce innovation and technology to the primary healthcare. There was no standard definition. There was no standard definition about the primary healthcare at that time. So we defined it ourselves, and ultimately we found that anything which can provide solution to the problem being faced by the primary healthcare, the use of technology, they are the right thing which we consider as a innovation. We did a lot of work to find out what are the innovations which has been tested in the past, and ultimately came down to 6 buckets of the innovations which I have shown here in this slide. They are innovations which are related to information, communication, and technology. They are innovation to device, equipment, and product. They are innovation related to the infrastructures, financing, social marketing, and so on and so forth. So these 6 buckets were defined. Then we worked out the filtration mechanism so that we can identify what are the top priority innovations which can be fitted into our primary care system. And what has been told by my previous speaker, it was particularly related to the Aam Aadmi Mohalla Clinic. It was related to our Rajasthan model, which Sir Muralidharan has recently talked about. We try to put these innovations after putting them through this filtration mechanism. After bucketing them, we worked out a ranking list who are the priority number 1 solutions, priority number 2 solutions, and there was a scoring criteria for that. And that way we entered into technology integration into the primary healthcare, which has been elaborated by the previous speaker in the urban as well as rural model. This was the feasibility study. There were about 100 innovations which we have tried to put up in the primary healthcare, and these innovations, when they were put up into the primary healthcare, they are called as a feasibility study. Whether this system is accepting it, whether the end users are accepting it, whether the public is getting benefit out of it or not. And thereafter, we subjected some of them to health technology assessment, which is the science. And this will tell you whether they are effective and they are cost effective. So this is how we processed our work to reach to the present stage, which Dr. Rajesh Khanna and Mr. Rajesh Singh has shared with you. At present, in the comprehensive primary healthcare, we have got about 100 centers which are working in partnership with the government, and they are operating at the sub-center level, which cater to the 5,000 population, which we call digital health and wellness center. They are working at the rural primary health center, which is catering to 30,000 to 50,000 population. We call it rural primary health center of digital nature. It is catering to the urban primary health center, which Rajesh Khanna has defined. And there is a value-added model, which we call continuum of care. It means you take care of the referral during the golden hour up to the referral post so that patient gets the right service during the golden hour. Now, this PPP comprehensive primary healthcare approach provides all those services which are prescribed within NHM and now in Ayushman Bharat digital mission. There is a little provision for the inpatient services, and that means those who want inpatient delivery or those who need some type of IV alimentation on account of dehydration, that can be taken care over there. But rest of the patients who need referral care are usually referred by application of technology and digital system, either through 102 or 108 to the secondary or tertiary healthcare post. We expanded our innovations from 2016 onward now to very many things which take care of health prevention, health promotion, treatment, and follow-up. And cover wide of wearable, telemedicinal technologies, innovations and technology. They are just efforts for bridging the gap so that we can deliver service more faster. But still, I will say that there is a long way to move forward. The technology has given results which are far ahead of what the digital system in India in the primary healthcare has been able to. So we are thinking of reaching up to that also in due course of time. Now, if we try to look at the present scenario and what goals we are keeping for us under the wish, our aim is in tune with the National Health Policy 27 and NDHM and Ayushman Bharat Digital Mission. And this aims is largely focused to the NCD because they are outnumbering the communicable diseases. And that aims demand reducing premature death, what they call avoidable death, by 25% up to 2025. And all these avoidable deaths have been prioritized in the National Program for Cancer, Diabetes, and Stroke from tertiary up to the primary healthcare level. So we coined our strategy for future for identifying critical gap in the primary healthcare services as per NPCDS, which we want to fill with the help of technology, whatever range is available and whatever type of technology is available, either as an indigenous product or as a product from the IIT teams or various innovators, identifying them and using them and putting them, and they are cutting across the number of the various subgroups which we have talked about. So this is our initial priority issue which we are keeping before us for the future. Now, having said that, how do I try to look at the future with the help of these technologies which we have tried to imbibe within the primary healthcare system, where we have seen in non-COVID as well as COVID period, a relatively very high value of acceptance among the end user and a large amount of partnership and appreciations from the NHM in the various state government and the center. How we are trying to look at it, contextualize it with our future. We look at it from the point of view of togetherness, betterment, and tomorrow's vision. Now, when we say togetherness, it means health technology, digital in nature, which is initiated by government, need to be blended or hybridized with the primary healthcare strategy. We know primary healthcare strategy is comprehensive primary healthcare strategy. We are unsure about the amount, the range of the digital technology which are available, but we are gradually using them, finding them useful, and expanding the overall basket of the various digital solutions, which are coming forward before us. So we want to blend them together to create a model which best suits the need of the end user in the primary healthcare. The second one is a betterment. What betterment we are talking about? We are talking about a betterment which can create a verifiable event. There should be a verifiable evidence that this blended care is giving an improved health outcome. If I suffer from typhoid, I get diagnosed in the shortest possible time, have access to the medicine in the right amount, consume full doses, and get the shortest time the relief from the typhoid fever. That means that there is an improvement instead of getting it complicated. So our pathway for use the various type of solutions, digital technologies which we are integrating within the system depends upon our implementation science model, that is right design, creating a demonstration model, maturating that model in wider use, finding the gaps, bringing a solution, and then select a population as our population in which we will saturate the total population and try to see whether it is turning out to be useful or it is turning out to be useless. And in case it is useful, on the basis of our internal assessment, we will try to get assessed externally and ultimately take a view of the end user and give a validation report. So this is our pathway which we adopt for every new technology integration. Now our health model, which we are trying to create, which Khanna ji has talked, Rajesh Ranjan Singh ji has talked, these models have to become sustainable. For that sustainability, we have to then go through a process of creating a minimally viable product out of that, where wasteful expenditure, wasteful items are removed, and we create a rip-off model which is cost effective, or if we are not able to take, if it is not useful for the public, then we can create a good to have type of approach. The model which looks good, it is also having little bit shade of some avoidable expenditure, but it is absorbable within the system. This is for the model, which 4 model we have talked about. But they are digital product. They have to be HTA verified for its efficacy and cost effectiveness. And when I say about the tomorrow, then we have got only 2 global and national goals before us. One is NHP 17 and second is the Sustainable Development Goal. As per various reports, 2025, it is expected that the model which not which, but anybody creates as a hybrid model or a digital model need to be accepted in all the EAG states, oblique aspirational districts. And by 2030, it should be implemented wherever it is found useful in the states which want to adopt it. It is a type of optional acceptance which has been offered by the Ayushman Bharat Digital Mission to the state to improve their healthcare by application of the various digital solutions. There are certain policy direction which has been provided in the national health policy, as well as the direction which has been listed within the Ayushman Bharat Digital Mission. There are general principle of these policy directions. There is an influencer, which is a group of the experts like IIT, like the groups which are sitting in working as an innovator in various areas. There are enablers, which are Niti Aayog and Ministry of Health and Family Welfare, which can try to work out in partnership with the private sector. They are buyer of the services who buy services which are not available in the government sector, which is usually the government insurance system or sometimes a government partnered private insurance system. There are various type of facilitators who works at the primary healthcare level, in which I will quote, which is one of them. They facilitate the overall growth of the healthcare sector. And there is a money spender which should shift from patient's pocket to the government spending. And government has said that 2/3 of the money which they budget in the health sector will go toward the primary healthcare sector. And simultaneously, they have imposed a limitation to the secondary and tertiary healthcare sector. That only 1/3 of the money from the public health spending will go to the secondary and tertiary sector. So these are the general principle which has been provided in the policy directive as issued by the Government of India in 2017 and now in the Ayushman Bharat Digital Mission. The policy direction number 2 is a little bit more crucial. The policy direction number 2 says that health is not a service. Health is in our development agenda. If we hybridize the digital technologies, digital solutions, innovations, new variables within the overall healthcare delivery, we create a platform for development, nation building, and that's why they have included it in the development agenda, and its development goals can only be achieved by a partnership of all the stakeholders. And who are these stakeholders? These stakeholders are the various type of partners who contribute towards the healthcare. A group is there, which are medical professionals. Another group is who are supporting the medical professional. Then there are hospital industry. Then there are various type of pharma industry. Then there are various type of initiative which has been taken up by the government, like Digital India, like biopharma missions, like medical device park, AMTZ, like pharma park, which is coming up in UP, like Startup India. There are new investment areas which will add value to the health delivery in the primary healthcare section on one side, and on the other hand, it will try to create a developmental upthrust for the country. And Government of India is committed. In 2016, they were having expenditure of 1.15% of GDP. They have said that they will increase it by 2.25% of the GDP gradually. And that gradually word has been unexplained. Most of the time it is said it is up to 2025. If you look at the today's expenditure, as for the GDP, it is only 1.5% of the GDP. So this slow investment coming in the health sector gives a big gap for which health as a developmental system can get more and more funding if more and more digital solutions are identified, nurtured, developed by the academia, and tested in the primary healthcare system by small NGOs like WISH and many more, and ultimately translated into a product which can be made available for the program as well as for the open use to the larger population for prevention. You look at only wearable. India is 98% import dependent. Only 2% we are attempting manufacturing our own things, not end to end. It is assembling more or less. So there is a big gap which is available, and there is a big investment which can come from the Government of India side by putting this second policy direction, which is health for development. And the third policy direction is growth-oriented healthcare. Now we have been considering healthcare as only spending type of item, never thought that it can add to the economic growth of the country. But National Health Policy 17 said that healthcare can add value to the economic growth. And the criteria which they have taken, the criteria was more or less like if there are big inequities in the health, some are getting the best health, they are very few. Majority are getting the bad health care, and they are very large in number. To make it very simple, they die because they don't get health care. They get morbid complication because they get delayed health care. They get disability because they get bad health care. Now, this is something which is directly impacting the GDP growth. If we try to improve the health outcome by integrating the technology, we will reduce this inequity. And if we are able to reduce the inequity, we will have a better GDP growth. And if we are not able to do it by any means, and I say that it is integration of the digital system within the healthcare delivery wherever it is appropriate, we will never be able to achieve a growth-oriented healthcare. So this policy direction number 3 is relevant, and they will be all measurable. Now, look at the government of India working in this direction. 2014 onward, they try to ease out all regulatory system. There was a Made in India, which was launched in 2014. And in 2017, they have been able to tease out the rule and release the medical device rule, which initially was not having the medical devices within it. It was carved out. Then the DCGI Act was modified, and in between Andhra Pradesh, at that time Andhra Pradesh, now in Telangana, they have opened up even a medical device park. So this is the government effort to ease out the things so that more and more things are made available. And why all these things? They are all there for supporting the universal health coverage, which means cover uncovered area, reduce cost, and put in more money. And there is one more thing which I would like to put up. At present, as far as
May I request participants to mute their audio, please? Yeah. Please go. Go ahead, sir. You are muted. Yes.
now, there is a big demand and supply gap as far as these products are concerned. And this gap exists not because we are not moving forward. This exists on account of two things. That government has taken new initiative in a fast track, which has generated a market, and the importers from foreign countries have invested a lot of money in capturing this market. So government action as well as the market has put up a doubling effect on augmenting the demand and supply gap. And this demand and supply gap cannot be bridged by sporadic effort by creating some type of research center in ICMR, like they have created a National Center for Assistive Technology, which is partnering with IIT and AIIMS-like institutions, or some type of partnership with big imaging industry like Philips and etc. By the private sector, so that they can create the product in India. This big gap can only be bridged if we understand where the priority lies. Priority lies in the primary healthcare system. And primary healthcare system require low cost but high volume type of digital product. And they should be end-to-end indigenous. That is first thing. And they should be having a competitive business plan for the companies to take it up. Otherwise, they will succumb to the big, high cost and low volume type of product. So that is one area which is lacking. And it is something which has to be taken up by the government, because at present, there is nothing like this. If we look at the AMTZ, it is talking of secondary and tertiary healthcare. If you look at the digital pharma, it is talking of cancer drugs, third, fourth generation antibiotic, but nothing about the common things which are needed for the digital solution. The second thing is, it cannot be done by the sporadic effort like WISH is doing or many other organizations. It has to have a full chain system. The product immersion, prescription, training, and follow-up, so that it becomes sustainable within the healthcare system. And for that, all the stakeholders must sit together, build up a strategic framework for the digital technology immersion, and sole aim should be to reduce or zero the import dependence. I am not a business person, but whatever I know about it, that at present, the biggest investment which is coming from FDI is in this sector. So I hope why I am not moving to the next.
Right, sir.
So this is all I wanted to talk about the product as far as the digital health technology is concerned. And at the end, I would like to say, at present, we are not fully prepared. If we are trying to build up a model, we have to prepare more thoroughly. We are deficient in production, promotion, purchase, provisioning, and maintenance. And we need a time-bound national program, particularly focusing to the primary healthcare, because it takes care of the larger masses. And if it is done, we expect a outcome-oriented partnership among all the providers, a development of doable and acceptable framework, generation of evidence for a smart health outcome, and developing a dedicated part for the primary healthcare product for end-to-end production in India. With these words, I would like to thank you for giving me this opportunity to share some idea with you. Thank you very much.
Thank you very much, sir. And I would like to thank on behalf of everybody, you and the other two speakers. We have a couple of questions that either you or others can address, but maybe perhaps directed to you. One, Mr. Mubarak Ali has posed a question. What exactly does digital health mean? Does it change how does it change the healthcare industry? That's his primary questions. And we have one or two more questions we'll take up.
I will respond one by one. So if you permit, I will respond to first.
Yes, sir. Yes, sir. Yes.
Digital health is defined by WHO in the guidance document for the digital health. It was somewhere in 2018. It is also defined in the NDHM and Ayushman Bharat digital mission. There are three cardinal components of the digital health. Number one is it is complementary and supplementary to the physical health care services. It is not a substitute to healthcare services. Number two, it uses all the type of technology which are either of mHealth, eHealth, digital health, AI-based within its ambit, so that it complement and supplement delivery of the healthcare. And the third thing is that all these type of technology should be verifiable with evidence to better the health outcome. So with this definition, if it is at all falling within the framework of definition, I think digital health can become a type of omnibus package for all the technology-driven solutions. Does it satisfy the person raising the question?
Yeah. So I don't know if he's going to respond to that. But there's one other question. How digital health by one person by name Rekha, while we talk about transforming to digital telemedicine consultation, are we also focusing on demand generation? Can we enhance the demand through application of digital platform?
Yes. I will try to elaborate on this question, the response to this question. The question is that if we use telemedicine, can it increase the demand? Now the answer is based on two evidences. First evidence is the data which are available from other countries. These data shows, if you take the US data or EU data or UK data that before introduction of technology in the public health system, the home-based or domiciliary care was finding less user. But after making digital technology as an integral part within the healthcare system, the domiciliary care have become one of the most sought after type of care for majority of patients. So these data suggest that when we introduce technology and a technology which is acceptable by the end user, there is an increase in the demand. The second data which are available with us, and that data was shared with you in the urban model as well as in the primary healthcare model. And the graphic representation has shown the number of consultations which are coming for the digital technology, and it is spiraling high in any of the model. I am again saying in COVID period and non-COVID period, both period. So it also says that there is a demand increase on account of the technology integration. Now, this is part answer of the question which has been raised. But the part answer which has not been attended by me and for which I don't have an answer as well, is what it has produced as an outcome. That is more relevant to me, that whether it has given an improved health outcome at sustainable cost, that outcome I will not be able to share with you. Maybe next time, sometime when we'll meet, we will be able to share with you.
Sir, thank you very much. There's one more question related to Dr. Rajesh Khanna's presentation. You had mentioned that repeat patient, the data on repeat patients is a sign of trust of the system. We also, in our pilot, felt the same way. As the repeat patient proportion goes up, it means that the trust in the system is enhancing. We found, but we still found that the question I'm elaborating in my own way. There's a question from one Mr. Rajesh. Says, is there a way in the 3PAP system or other features that you can build in that will also help us monitor compliance of the patients, particularly for NCD treatment regime? This is the question. Is that tough? Still.
Yeah, and yeah, no, very interesting question. And what we have found so far is that when we are looking into the classification, what we are seeing is that predominantly nearly 35% of the patients are coming up with respiratory tract infection, and that could also be attributed to the fact that you had these facilities were functional during COVID pandemic. So a major proportion of them are this. However, there was another question related to it. It was just above. It was related to communicable diseases. So in that scenario, we had some related to diarrhea and other gastric related problems. They were about 11%. For NCDs, surprisingly, we found that nearly 9% of the patients are coming. 9% of the patients had a diagnosis of NCDs. Now, I don't have clear evidence to say that we have been able to follow it. But what we are realizing is that your 45% of the population that is accessing these services is in the range of 30 to 60 years. And so I can't say, for example, but this is all corroborative evidence that, yes, NCDs are being diagnosed, but if I say that can we ensure that they are being followed up properly, that is something where it will take some time. Now, fortunately, we also have a mechanism with the government focusing of NCDs that the screening can be done at the primary care level, which has to be done by the frontline, identifying those high-risk patients and then bringing them to the primary healthcare facilities for diagnosis. So your high risk mapping is being done at the community level through the frontline health workers, and those who tick those 4 high risk factors are being brought to the primary health centers for diagnosis. If there is a need for further tests, then they are being referred. So I think we need to, this continuum, there is a potential with this clinic that we will be able to break it. But at this point, I will say that we have got some flavor of it, but we have not been able to completely follow end to end.
Just to add,
Yes, please.
Professor
Yes, sir.
Muralidharan, to Rajesh point, what we saw initially that, considering the compliance for the non-communicable, and especially hypertension and diabetes, right? We actually, in the pilot stage of proof of concept, we really limited the medicines to only 3 days, knowing that these are costly medicines, like, and especially hypertension and diabetes cases there. And we found that the repeat visits started happening, knowing that every repeat visit is considered as a consult cost. So consult costs started increasing, and we went to the government, because 93% of the people who were on these 2 drugs, like disease-related drugs, they were coming every third day, means 4th day they were showing. Then we convinced the government, and we that no, I think they are all the factory workers, casual laborers, like someone who really assisting in home. Why do they lose the wages there? And they increased it to 15 months. We still find that the repeat visits for these patients are very high, and especially these 2 non-communicable diseases there. Now, whether it really answers the compliance part, partly yes, but there's no solid data to say whether after 3rd day when they visited, I actually consumed but it's a that the patient came to us when they exhausted the medicine, and they may have used it.
I think, if I may extend the question my own way, that if since we know the identification of the patients and where from he or she comes, those who have been above the permissible level or the threshold level, they can be picked up, and a household visits about, and then an IEC campaign or elicit information about the drug consumption pattern as a follow-up, as a part of the treatment mechanism, perhaps could supplement the efforts being made. So I have one question to all 3.
Muralidharan, can I just attend to your question last little bit?
Yes, sir. Yes.
I was in government, and government used to run a central government health scheme, which has got large number of beneficiaries, and we prescribe medicine to them. The same thing which is happening with the primary healthcare now, 3 days, 7 days, 10 days. And the same type of questions what you have posed now was posed by the end user. So in a period of 10 years, government has evolved a system when by a single visit, they can get medicine for 3 months.
Yeah.
Okay. Now this 3-month medicine is needed by a person who is CGHS beneficiary for diabetes, hypertension, and it is acceptable by the government system. But the same type of patient, if he is in the primary health care, he has to make number of visits which cost to the system and which make a life difficult for the end user. So what I am trying to convey to you through this story is that models are available with the government, and these models require replication, and that is where I told you that there should be a stakeholders consortium to put before to the government a type of framework for solutions. Like you said, there should be a home visit, there should be a telephone call on the day, and all these things should be integrated at one place. Otherwise, it will keep on happening like this. Small wish organization or some other organization will feel happy from 3 days to 6 days, 6 days to 10 days, but that is not a solution. It is a continuous process. That is the one thing I wanted to share. Thank you.
So one question finally on behalf of everybody and myself. When I visited your foundation and near Jaipur, about a 2 hours drive from there, a PHC adopted by Wish Foundation. There was a laboratory and you had many equipment, diagnostic equipment being used. One of which was non-invasive hemoglobin measurement equipment that you just wear it as an eyeglass and then it measures your hemoglobin, and I got a high hemoglobin level of 15, which matched with my previous test. So very casually I asked whether you are comparing this data with regular hemoglobin test being done to the patient. But so there was actually at that time they said they have not yet done it. So my question is, a number of these digital equipment technology that you've introduced as part of your working with the government, are you doing an effectiveness study of these instruments vis-a-vis the standard care of care, which is also being provided? And that would be a very substantive way of pushing many of these digital equipment into the public system, evidence-based. It's a very general question to you, and we'll close with that. So you're muted, sir.
It is a very standard system in which that when we take an innovation like hemoglobinometer, which was a conjunctival hemoglobinometer, which we put down to the feasibility study, after getting that result, which was showing that it is widely accepted, we compared these results by subjecting the same blood sample to the standard test. And in that standard test, we found that there is a gross variation between the range of 6 to 8. It means at the level of 6 or below, we have to go down, 7 or below, we have to go down for injectable infusion. And 7 up above, we have to maintain on oral. So we did not recommend this. So our standard practice is that once we complete the feasibility study, before recommending it to the government, we compare the test with the standard method. And if we find a good comparability with the least amount of variation, we recommend it for wider use in an incremental manner to the government. Hope I have answered your question.
So I was generally asking whether it is done on the field in different time zones, seasons, and so on. And are they published so that we can have access to such interesting studies as well?
I don't know whether it is published or not, but the report should be available here. It should be available with the Jaipur team. And it is particular. You can have. You can write to us. We will provide you the report about this.
Thank you, sir. Thank you, sir. That would be lovely. So, on behalf of the ARDO IIT and organizing team and all the participants of this webinar, I would like to thank the special invited speakers, Rajesh Khanna, Rajesh Singh, and Professor Srivatsa. I would like to now hand over the platform to Sudarshan Bhattanathan.
Well, thank you very much once again on behalf of SIDDHI IIT Madras and also Office of Global Engagement IIT Madras, the Dean's Office, and our team. Actually, I thank Professor Srivastava, Dr. Rajesh Khanna, and Rajesh Singh ji for giving such a wonderful and elaborate presentation on how private and public partnership can work in primary health. Now I hand over the microphone to Vinod of the Office of Global Engagement, to give a formal vote of thanks and also to give a account of what is going to happen tomorrow. Just a brief recap of the events for tomorrow. Thank you very much.
Thank you, Professor. And my apologies for the network issues that happened at the beginning of the session. It gives me immense pleasure to deliver the vote of thanks to all the participants who had joined today's program via Zoom and YouTube. I would like to thank all the speakers of the day from Wish Foundation, Mr. Rajesh Singh, CEO, Dr. Rajesh Khanna, Senior Director, Programs, and Dr. R.K. Srivastava, Senior Advisor for Innovations and Public Health. I thank Professor V.R. Muralidharan for efficiently moderating the session. I also owe my special thanks to Dr. Sudarshan Padmanabhan, who consistently follows up on the overall coordination. Thank you, sir. And kind information to the participants, please do make your presence without fail tomorrow. The title of tomorrow's discussion is Healthcare Database in India. Dr. Amit Mishra, consultant from Ministry of Public Health, Qatar, is going to be the speaker, and Dr. Girija Vaidyanathan, retired IAS officer, former Chief Secretary, Government of Tamil Nadu, is going to moderate the session. Thank you once again for joining. With this, we are ending up the day 2 session, sir.
Amit Mishra was with the NHSRC. He has worked for 7 years on Indian database, and he has recently written a paper on the same topic, which will appear in Journal of Health Management. And he's currently working with Qatar. So that's the background of. Thank you once again for everyone, sir, and on behalf of the participants from our African colleagues, countries. Bye-bye.
Thank you very much.
Bye-bye.
Thanks.
Thank you.
Bye. See you then.
Thank you all.
Bye.